Hey y'all, welcome back to From the Ground Up. I am so excited to dive in. We're doing a little bit of a controversial topic today, which is always my favorite because I love to push on some buttons in a loving way, in a way that just encourages, using our brains and thinking about why we do what we do and why are we making certain choices and treatments and things like that. So I'm very excited to dive in. Before we get to the meat and potatoes, I did want to make just a quick little announcement that I am going to be hosting a free live virtual foot and pelvic floor workshop for pelvic floor therapists and coaches. It's going to be on September 23rd. So be sure to sign up for that. And you can find that link in the show notes. I ran this for the first time last spring and I had over 600 people sign up and it seems like everyone really loved it. So I'm going to do it again. It was really, really popular. Make sure you don't miss it. Again, you can sign up in the show notes. The link will be there and it's on September 23rd. So be sure you do that if you're interested. All right, let's actually get into the meat and potatoes today. So there are two main schools of thought when it comes to internal pelvic floor work or assessment. On the one hand, this school of thought is that internal work is the holy grail. It's what sets pelvic floor therapists apart from other, PTs, OTs, coaches, and that it's extremely necessary in pelvic rehab, that we're performing internal exams and internal manual therapy for our patients. And of course, caveat, this is assuming we have patient consent. That's not the point of today. As we go through this topic today, just assume that the patients all have consent that I'm talking about. Because of course, if a patient doesn't give consent, we're not going to do internal work. So that's my one and only disclaimer, and it applies throughout the entire episode. So that's kind of side number one, is this idea that internal work is the holy grail. It's what sets us apart as pelvic floor PTs and OTs. And then the other side of the pendulum swing is that internal work is not necessary and that you can be a pelvic rehab provider without internal assessment and without internal manual therapy because it's just a tool. And maybe I get way better results with exercises and other lifestyle interventions anyways. And I can, market myself as a pelvic floor PT or OT, even though I don't either utilize or I'm not trained in internal assessment and treatment. So those are kind of the two schools of thought that I've come across when it comes to internal pelvic floor work. Now, I believe that there is nuance to this, like I believe with most stuff. I am a pelvic floor PT who does utilize an internal exam and internal manual therapies for probably 95% of my in-clinic, in-person patients, y'all. And I will say most or almost half of my caseload right now is virtual. So I'm seeing a lot of virtual patients, and then, the other half is going to be in person in my clinic. And so obviously with virtual, there's no internal assessment or internal manual therapy from my end. And I also want to say I wouldn't take on virtual clients if I didn't believe and know that I can help them, frankly, even without this internal assessment and internal work for them. The internal exam and internal manual therapy is simply a tool that can be very helpful in gathering information about our patients' pelvic floors more than simply this muscle's tight, this muscle is tender, by the way. So, we're not only finding out that information with the internal exam. And internal manual therapy is a tool that truly can make a positive impact on our patient outcomes. But of course, it is not our only tool. So while I do very much utilize an internal exam and internal manual therapies in my in-person pelvic floor clients, I don't believe it's necessary to be an incredible pelvic rehab provider or to help people fully overcome pelvic floor dysfunction. And if that's the case, right, if I believe that to be true, if I can help people virtually overcome their pelvic floor issues without any internal work, why do I use it in the clinic then? Right? So that's kind of the tension I want to hold today and what I want to kind of walk through with you guys. Specifically, I want to cover why internal work is frankly not necessary in pelvic rehab. So strong belief number one, it's not necessary. But also why internal work is still a very helpful tool in pelvic rehab, even though it's not a necessary tool, y'all. It's very helpful, even though it's not necessary. And I want to talk about how I utilize internal work with my in-person patients. And I want to talk about how I help people fully overcome their pelvic floor dysfunction virtually without any internal work. Okay. Both can be true. So let's start with kind of this idea that internal work is not necessary in pelvic rehab. It's true that internal palpation and manual skills are something that pelvic floor therapists are trained in when other, PTs, OTs are not. They don't have the training in internal vaginal rectal assessment and manual therapy. This includes pelvic rehab chiropractors, coaches who market themselves as kind of pelvic rehab coaches, people like that. Yet, these other providers are clearly out here helping people with pelvic floor conditions, and they're getting them results. Wow, but they're not doing any internal work, right? So I kind of wonder if pelvic floor therapists like to hold on to the idea of internal work being so sacred and such the holy grail to our specialty because it is one skill that sets us apart from others. And even though that's true, I would ask, does it make us better though, just because we have this skill set that others don't have? Does being trained in internal assessment manual therapy make us better than the providers that are not trained in that or don't utilize that? I think what makes someone better is not fancy skill sets that other providers don't have. It's actually going to be the willingness to be curious, to admit that we may not know the answer just yet, and to go out and find it for our patients rather than relying on these quote unquote fancy manual skills, right? Because I'm telling you right now, there are hundreds, probably thousands of internally trained and treating pelvic floor therapists who are frankly not helping their patients overcome their pelvic floor dysfunction despite using internal manual therapy each and every visit. I have these patients in my clinic. I am seeing them virtually. They have all received internal manual therapy, yet did not get better, y'all, or at least not fully better. They got stuck. So if it's not the internal work that is going to help them, what is the thing that's going to help them? Well, we might deduce then that it's the absence of internal work that's going to help them. And I would actually argue it's not the presence or absence of internal work at all. It's the provider themselves. It's the PT, the OT, the coach who knows how to truly find the root cause in their patient. And then they know how to decide which tools that they have in their toolbox will be helpful in treating that root cause. And then they know how to take them beyond just symptom relief into true lasting resilience. That is what makes someone better than the others, okay? And that's why I'm able to help my patients achieve their desired outcomes in the clinic or out of the clinic, virtually or in person, right? I know what questions to ask and what assessments to do, manual assessments and observational assessments, right? To find the true root cause of their leaking, of their prolapse, of their chronic pain, their sciatica. The list goes on and on. I could rattle off literally everything, right? When you have a method to use, you will be able to get to the root cause because you're following kind of this framework that is proven to help you do just that. So once I determine the root cause or causes, right, in my patients, then I have a wide range of tools in my toolbox, in my pelvic PT toolbox to choose from. And I know which tools are going to be the most helpful, both for quick results for my patients, quick wins to help with buy-in and to help them kind of stay motivated, and also for those longer term outcomes, because there is a difference between the two. There's a difference between interventions that I'm doing to help them feel better quickly now, immediately, like after this session today. And then there's differences in the interventions I'm doing that I know is more of a long-term investment, a long-term gain, a long-term win. Okay. They're different, but they're both very important to your patient's journey with you. And those tools, they're things like manual therapies, right? Internal and external manual therapies. We have dry needling, we have cupping, we have joint manipulation. All of these are things that I use with my in-clinic patients. It's also the exercise interventions, right? It's looking at biomechanics and looking at movements. Of course it is. Of course it is. And it's educational intervention, right? It's teaching them things, giving them ways to help them learn new habits and changes to make in their day-to-day lives. Things that are going to, move the needle in some of those daily habits that are contributing to their symptoms. It's also knowing other collaborative providers to refer them out to, because I can't and I shouldn't be trying to do it all. Okay. It's understanding that at the end of the day, I am not treating bones and muscles and joints, really, right? I am treating a nervous system that has bones and muscles and joints. And it also has thoughts and feelings and fears and hopes and dreams and all of these things, which all matter in their rehab process and for their outcomes. And that is perhaps your most important tool, is this kind of attunement to their nervous system and building this trust with your patients and helping them to believe that you're the person that can help them and then helping them, right? All the fancy manual work in the world, internal or external, or the fanciest exercises, and I like me some fancy exercises, okay? They're not going to do anything if we don't understand the drivers behind our patient's symptoms, if we don't understand our patient's beliefs about their bodies, their abilities, their pain, their symptoms, and if we don't know what's important to them, okay? So it doesn't matter if we do internal or external. And that's what I mean when I say internal work is not necessarily necessary in pelvic rehab. It is a tool that can be really helpful. And so that being said, let's talk about that. Let's talk about how even though internal work is not absolutely necessary for pelvic rehab and to help our patients with pelvic floor dysfunction, it still is a really helpful tool for us to use in pelvic rehab, okay? Like I have told you, internal assessment and manual therapy is still a tool I very much use with most of my in-person, in-clinic pelvic floor patients in most of their visits, okay? I'm doing it a lot, y'all. I find it really helpful to confirm like what I'm already thinking I might find, right? So maybe I confirm that they have an angry OI based on what I saw in my movement assessment earlier. And I want to go palpate it and confirm it. Maybe I confirm that they have a short posterior pelvic floor based on the posture that I see that they tend to stand in or sit in and the fact that they leak when they sneeze, right? I can probably guess their posterior pelvic floor is going to be a little tight, okay? Maybe I go confirm that they have asymmetries from one side to another based on the hip injury that they told me about that they had years ago. Okay. Confirming with palpation can be helpful to you to confirm what you thought to be true about their pelvic floor muscles. But also, it can be really helpful to the patient themselves, right? There's been many aha moments with my patients when I've, let's take an example, palpated their obturator internus muscle internally, and maybe it reproduced their bladder urgency, for example. And it really helps them to make that connection for the patient when I give them, say, certain interventions for this muscle, right? They can understand because they remember, well, yeah, when she palpated that muscle, it reproduced all of my symptoms, right? They can understand it's connected to the urgency and they can believe it'll help them, right? Because remember, what patients believe about their body is extremely impactful to their outcomes. And not only is internal palpation assessment so helpful, but also being able to perform like myofascial work internally. So not just assessing, but also treating, right? Manual touch is like magic to tense muscles on a lot of people, especially when your patients feel safe and they trust that what you're doing will help them. Internal release, right? Internal release to an angry obturator internus or to a coccygeus muscle. That can be so helpful. When they then go to do an exercise, I give them maybe that requires, let's say, hip and pelvis internal rotation, right? They move better because I did some myofascial work and, some of that tension was able to kind of melt away, if you will. So now I give them the associated exercise and they move better. And that can improve the effectiveness of the exercise. Another huge reason internal, like manual treatments, internal releases, whatever you want to call them, can be so helpful is because patients feel better after you do it, generally speaking, right? And this is especially in pelvic health. It's huge to get buy-in and belief that they are working with someone who can help them, okay? This is kind of that, what I was talking about earlier, short-term improvements in their pain due to manual therapy can be so beneficial in their overall patient journey because it builds trust. If they feel better, even a little bit better after every visit with you because you perform some manual therapy, that is huge. Is that going to make the long-term changes because you're doing manual therapy every time? No. but it still has a place. It can still be a useful tool to help them continue to enjoy their time with you, have these positive beliefs about their body's ability to heal, right? When they feel better after their sessions with you, they trust that you are helping them. And that's a good thing. That is a good thing. It is still important, though, to frame it in a way that doesn't create that like reliance on the manual techniques, right? So for example, if I am doing internal work on a patient, after every time I do it, they're like, oh my gosh, like my pelvic floor muscle tension just melts away every time you do that. I need you forever. I'm going to, be seeing you forever because this is the only thing that's helping. It's very important to have been educating our patients on why. Why am I using this manual technique? How is it going to play into your short-term and your long-term rehab journey? And be upfront and honest with them. I might tell a patient in that scenario, I'm using internal manual therapy to get some short-term changes in your pelvic floor muscles so that when you do your exercises with me today, when you continue to do your rehab homework, your rehab exercises at home between our sessions, you're going to get more out of those things. And that is truly what's going to do the long-term work and what's going to help us reach your long-term outcomes and build this lasting change and this resilience from the rehab process. It's not the fancy manual work I'm doing. That's a helpful tool to help us get more out of it. But that's all it is, right? I'm not a wizard. I'm not over here working magic and casting spells on your pelvis and doing all these things, right? My hands are normal hands. And it's important to help our patients understand that as any type of manual therapy, not just internal, like even dry needling, right? Like I am very careful to tell my patients, dry needling is the closest thing to injecting a drug that I got, okay? It is so beneficial and useful and literally like magic 24 hours after you do it, right? You stick that sucker in a trigger point and my patient will come back the next week and they're like, oh my gosh, the next day my pain was gone and I haven't had pain in 7 days and you are so magic. And I'm like, no, I'm not. Actually, let me explain to you how dry needling works and the mechanism and why I did it. It's not because this is the magic thing that it's going to get you lasting results. I mean, you're going to be seeing me forever. If that's the case, I'm going to be stabbing you with needles for the rest of time if this is my only intervention and my main intervention. Okay. So it really, really matters what our patients believe about our treatments and what we're telling them about our manual treatments, whether it's internal or external, exercise-based, whatever it is. It's important that they know your why behind using those things. So let me talk a little bit about how then I utilize internal manual therapy with my patients. Like I said earlier, most of my patients who I see in the clinic receive some form of internal manual therapy. Vaginal, I don't treat males, I only treat females. And so vaginal internal manual therapy, rectal internal manual therapy, most of my patients are getting both, y'all. They're getting both. And you might be asking, well, why the heck would you have to do rectal work on a patient with bladder prolapse or a patient with stress incontinence? And maybe they don't even complain about quote unquote backdoor symptoms. They don't have constipation. They don't have fecal incontinence. They don't have tailbone pain or whatever those kind of mainstream posterior backdoor pelvic floor symptoms might be coming up for you. I want to challenge that, and we can do a lot for all of our patients with rectal work because we can reach the posterior half of the pelvic floor way better that way. Can we reach it vaginally? A little bit, sure. Can we get as good of leverage? Absolutely not. And so that's just my little caveat that the vast majority of my patients, no matter what symptoms they're complaining of, they get both vaginal and rectal treatments throughout their care. Maybe not every single time, but like I'm utilizing both of those tools typically at some point with all of my patients. And it's because the posterior pelvic floor muscles play a huge role in things like leaking and bladder prolapse and hip pain and, literally everything. So it's so important and beneficial to be able to do that. But there's my little rabbit trail for my case for rectal work. Okay. But how I use this stuff with my patients is I am constantly framing it as a tool that I use to help them overcome their symptoms, right? I explain to them the various ways it works. It increases blood flow. It helps to decrease muscle tension. It can help to decrease pain, and depending on the patient and how they like to understand, some of my patients like to understand the more nitty gritty how than other patients. And so if it is a patient that's like, tell me more, I might go into like the nervous system with them and like how, what is pain? And it's this output, not an input, and all of these things. And so, and how manual therapy plays into that and plays into how the brain sends that output of pain or doesn't send it, right? It decreases guarding, muscle guarding. Again, that's by way of nervous system. And I pick and choose my patients of who I explain that in depth to, or some people I just say, yeah, this helps you decrease your muscle guarding. And that's that. It improves awareness of the musculature that so many of us never even knew existed, right? I didn't know anything what a pelvic floor was. I don't even think I knew muscles were there until I was in literally PT school and I had like my one little 2-hour niche lecture on the pelvic floor muscles. And I was like, oh, yeah, I guess there would be muscles there, right? But that's like the extent of what I knew, and I'm a PT. But like our patients are not usually PTs or even in the medical field. And so even just educating them as we go through this internal assessment, internal manual therapy is really beneficial to help them just be aware that there's muscles there. It's a part of their body. It's good for them to understand and know what's there, right? And what it does and all of the things. And it just gives me lots of info, especially over multiple appointments, right? Because I kind of have my benchmark in the first appointment or in the first few appointments. And then as I keep going over multiple appointments with them, it gives me lots of helpful info of changes that are happening to the muscles themselves, to my patients' pain levels themselves, just kind of what's happening at the pelvic floor due to the other interventions. And that's kind of the way I'll tell my patients is, hey, this is just a great way to just continue to assess the changes that are happening at your pelvic floor muscles. And I'm careful to say, like, let's say I'm palpating and I'm like, oh, your trigger point is gone, whatever. Like there's no more trigger point in your obturator internus today. Wow. I will tie that back to something active that the patient themselves has implemented. You know how you told me you've been doing this one exercise that targets this muscle specifically, or you know how we've really worked on regulating our nervous system and anxiety and breathing techniques and things like that. That is really what can be attributed to this decrease of muscle tension in your pelvic floor, right? So I always like to tie it back to what I'm feeling and assessing internally or working on internally, something that they're doing actively or will be doing actively. And that's kind of what helps them not become so reliant on the magic of manual therapy, if you will. And I explained that to truly correct, quote unquote, the dysfunction at their pelvic floor muscles, we do need to be doing these other interventions, right? Otherwise, you are going to be relying on manual therapy because it does work in the short term. And you're going to need it forever if we're not also doing these other things. And that's important to educate them on. So I'm telling them, that I'm telling them the importance of doing their home exercise program and making these lifestyle changes that I'm recommending, or these various referrals that I might be making, right? Mental health, hormones, nutrition, whatever it is that I've deemed kind of one of the root causes of their dysfunction, I'm making some sort of recommendation for something or to see someone or to implement something. And I reiterate to them often the importance of doing those things and not just relying on manual therapy. Okay. So if that's kind of what the language and what it looks like for me in clinic to utilize manual therapy, which again, I use almost every single session, internally and externally, vaginally and rectally with all my patients, right? How then am I helping people virtually without it? If it's such an integral and important tool that I like to use, right? Dry needling even. I can't do that through a screen. Unfortunately, I wish I could. But how am I helping people virtually without this internal work? So as helpful as the internal assessment and internal manual therapy can be for my patients, the reality is I can't do it for everyone, obviously. This includes those people who decline the internal work. That's not many of my patients, but I've had, probably I can count on one hand in my 6 years of being a pelvic floor PT, patients who declined and they didn't want the internal work, okay? And that's okay. That includes patients that have contraindications to internal work, right? I'm like thinking of people who are on pelvic rest in pregnancy, right? And the provider is like, nothing enters, okay? And I'm like, okay, I heard, understood. And, so that would be a contraindication. And then of course that includes the virtual people who, I am not there in person to do an internal assessment or to do internal treatments, of course. And because I already view internal work as a tool, not something that is necessary in my treatments as a pelvic floor therapist, right? It's something to confirm maybe what I'm already thinking based on subjective information and based on other objective testing that I'm observing through a screen, or as a way to enhance other interventions. This does mean that I can do it without it, right? Because it's just a tool. That's my belief. It's just a tool. It can be a helpful tool, but it can be done without it. So I really used to believe that if people couldn't come see me in person, it would be better to refer them to a pelvic floor therapist near them who could do the internal work, right? That's just what I used to think. Like, oh, if I got someone inquiring over Instagram or reaching out to my clinic and they aren't local, like step one, tell them, oh, well, why don't you find someone near you or whatever. And as time has gone on, I have honestly realized, and truthfully, as I've gotten better at my own method and my own approach to treating the pelvic floor, I've realized that I would rather them see me or my team virtually than many in-person pelvic floor therapists. And that sounds so terrible, y'all, but it's true. And of course, if someone inquires from afar, we do look, hey, where do you live? Like, let me see if I know a great pelvic floor therapist near you, and we will refer out, right? But if not, if I'm looking and I cannot find, if I don't know anyone where they live already, and if I'm Googling around and I'm looking at the websites of the pelvic floor therapists that I can find near them, and I'm like, ooh, these ain't it, right? We're going to take them on virtually because the care we provide at Genesis, even without the internal treatment and assessment, truly is far superior to a pelvic floor therapist who's just going to be doing baseline internal work, pelvic floor focused exercises like Kegels, or just focusing on like, oh, relax the pelvic floor, it's so tight, and never finding and treating the true root cause of this patient's symptoms, right? It's better to see me or my team virtually so I can actually figure out what the heck is going on. And I believe I usually can do that, than it is to see someone in person who won't be able to do that and who you're maybe not going to see any improvement, or at best 80% improvement, right? And, you're just going to think that you're broken and I guess no one can help me because I saw the in-person pelvic floor PT and I still pee my pants, or I still have pain, or like whatever it is, right? Even right now, I am seeing I want to say it's 8 women that are in my Resilient Body program. It's a program I launched through Genesis a couple months ago, and it's all virtual. And this is my first time launching like an actual live pelvic floor coaching program. We've always offered virtual visits, but never, in a cohort style, and never with a course attached to it. So this is kind of the first time we did that as an extension of our care, to get our care to more people. And in this first cohort, we have 8 women going through the program right now, all virtual, who are dealing with prolapse and leaking in the gym, right? And so we were clear on our messaging of who this program was for, so we could get these exact women, prolapse, leaking, preventing them from doing the workouts that they want to do, or they're just doing them and peeing their pants the whole time, right? Well, I was going to say they were leaking or having prolapse because so many of them are doing so much better. We're halfway through the 12-week program now, and they are literally, all 8 of them are seeing improvements already, and we're halfway through. These women have been to in-person pelvic floor therapy, y'all. They have all been to it and tried it. They've had the internal work, and they did not get better. And they describe their care to me, and I literally have to prevent my face from telling what I really think as I'm like listening to their stories of the care. Internal release, breathing, clamshells, bridges, Kegels, like almost all of them, this was their story. And they're from all over the world. We have Australia, we have the UK, we have different states in the United States. I mean, the people are all over in this program, right? And all of their stories are very similar, eerily similar, of the treatments they receive with this in-person pelvic floor therapist. And they have minimal or no improvement despite having gone for weeks and, months and months of this pelvic floor therapy, because they were told, whatever the case may be, that seeing someone where they can perform this internal work is better because you get the internal stuff than seeing someone virtually. And that's just not the case. here they are in our resilient body program. They're seeing me. A couple therapists on my team are helping me with the one-on-one portions. We have both a group educational setting that I run. So I'm educating them on pelvic floor function. I'm educating them on what prolapse is, why we leak, tension versus weakness, and that whole debacle of a debate. So they're getting all of this information through these group calls of this course, this live course that I'm doing for them. And they have these one-on-one sessions throughout where we can really get specific to them and their bodies and really be prescriptive of, exercise, habit changes, things like that. And they are improving. And many have only done like a couple one-on-one sessions, y'all. And like, this is possible when you have a reliable way to find out what's actually going on, right? This comes back to having a method, asking better questions, doing better assessments, prescribing better interventions. Like, just be better. Just be better. That's all I ask, because that's so much to ask, right? And that's what I'm out here trying to help you guys do, is to be better. And let's just make the field of pelvic health better. Okay. This is what I mean when I say, let's change the game. All right. I'm getting fired up because it really matters. Like, these women, these virtual women had tried the things that are supposed to be, the highest level of care, the internal treatments, and they literally did not improve. Okay. One even got worse. She got worse. And I'm just like, oh my gosh. And they're barely halfway through and they're already seeing improvements, and I haven't laid a hand on them. Okay. And I'm not like tooting my own horn. I'm just saying, like, there is a way to learn this stuff and assess this way and prescribe interventions this way. And you don't have to do it the way that those like level 1 courses taught us to do it, y'all. Let's think, let's use our brains, and let's do better for our patients. So to bring it home, no, internal work is not the holy grail of pelvic rehab. It is not necessary to help people overcome their pelvic floor dysfunction. And it can still be a really helpful tool for assessment and treatment when used appropriately, just like everything else that we do. So I really want to challenge you guys to like let that marinate a little bit and be curious about your own beliefs around yourself, potentially as an internally trained pelvic floor therapist. And what thoughts have you had about that? What have you believed about yourself? Have you believed that is what sets you apart from, coaches, from pelvic rehab chiropractors, from people who don't use internal? Have you had this belief that, well, I do internal, and so that's the standard of pelvic rehab? And, I used to think that. And then I learned better. And now I know better, do better. And now it's more of like, I have that tool and it's great. And I don't need it to help people get better, but it is something that I can choose to use if I want to. But if they don't want me to, or if they're through a screen, I still know how to get them better. And I still know how to help them change their lives and build this resilience. And honestly, that's how we change the game here. That's how we change the game of pelvic floor therapy. So if you found this at all helpful, please share this with someone, another clinician, maybe. Share it to your stories. Y'all, this is my life's work to get this word out. I live to help other pelvic floor therapists and coaches think differently and do better for your patients. And so if you found this helpful or insightful or inspiring or whatever, just please share it to your stories. It would mean the world to me. Tag me. That always makes my day when I see you guys are enjoying the show. And then lastly, just a reminder, the fall cohort of my signature course, How to Treat the Pelvic Floor Without Kegels, is starting soon, y'all. We get started in early October. You can check it out. If you found this helpful, the link is in the show notes. There is so much more in that course where this came from, right? This is my entire method, and I have it module by module for you in this course. And I would love for you to check it out. Make sure you're on my email list so you don't miss when the doors open. And I hope you guys all have a great rest of your day. Let's change the game, y'all.